blood pressure of 100 by 62 millimeters. Her creatinine is 1.89 milligram percentage with eGFR of 32 ml per minute, and she was on diuretics, digitalis, telmisartan, and MRA, which she stopped for last 2 weeks due to nausea and vomiting. She was hospitalized for heart failure 2 months back. Her hemoglobin is 10 gram percentage with low serum iron and high TIBC. What would be the best sequence for her after stabilization of acute decompensation?
Excuse me, slides are not there. Now it's. I will wait for a minute till the time they upload the slides over there. If we have a patient who has both kidney disease and heart disease, there is significant impact of coexistence of both the disease on each other. So, having both heart failure and kidney disease increases the risk of hospitalization, re-hospitalization, need for ICU admission and ICU care, need for renal replacement therapy, and definitely increases the chance of mortality. All right, thank you. So, this is the problem, that this patient has both kidney disease, significant kidney disease, and heart failure, so affects both. How does the impact of kidney disease on the heart failure occur? Let's see, one of the registry, that is Swedish heart registry, showed that almost 50% of patients who have heart failure have chronic kidney disease or acute on chronic disease. So that is a significant number of patients who are coming to us. In chronic, this is a busy slide, shows that in chronic heart failure, I'm talking about chronic heart failure patient, there is a progressive loss of renal function over time, because the basic soil remains the same, that is diabetes, hypertension, or etc., which affects both kidneys as well as heart. There is loss of nephron, there is loss of myocytes, both lead to decreased cardiac output, decreased renal function, and affecting each other, ultimately landing into something called as cardiorenal syndrome, and we all know that cardiorenal syndrome has very bad outcome. Worsening renal function affects all the patients who are there in hospitalizing for acute heart failure. We know that patient who's admitted with acute decompensated heart failure, ADHF, on admission usually will have creatinine of 1.9 or 1.8. a day, 2, 3, 4th day you do is serum creatine, it would jump to around 3, and this is very fairly common scenario. What could be the reason? The reason will be acute heart failure causing acute decrease in cardiac output, decreasing the renal perfusion. Back failure occurs that causes increased venous pressure, increased abdominal pressure, again causing decrease in the renal perfusion pressure, increasing EGFR and increasing creatinine. This can be temporarily or it can be permanent because of the loss of nephron functions. Can we do something for this? So what are the challenges in such kind of patients? What are the challenges of our patient? We want to give this patient a good dose of diuretic. However, we know that if I give a higher dose of diuretic, this patient's renal function will worsen. I want to give AS, ARB. However, knowing that both giving AS, ARB will, along with high dose of diuretics, will cause definite increase in serum creatine level. And what would be the reason? We know that RAS inhibition is must for any patient who has heart failure. Because RAS inhibition decreases the worsening of the serum creatine increase. That means doubling of serum creatine is decreased by giving any RAS inhibition, right? RAS inhibition is recommended therapy for any patient who has heart failure, and it is almost class 1A recommendation that whenever patient is there, whether it is acute heart failure or chronic heart failure, RAS inhibition is must. We want to give RAS inhibition all the patients. However, as I said, RAS inhibition will, along with high dose of diuretic therapy, will increase serum creatine level. RAS inhibition in such kind of patients will increase their serum potassium also. And this is a fairly common problem. In a patient who is admitted in ICU, you give RAS inhibition, give diuretics, their serum creatine starts increasing. You see their serum potassium also starts changing. Patient may develop hypokalemia also, or may develop hyperkalemia also. And the reason is because of decreasing the renal perfusion. All the major trials have shown that almost 13 to 20% patients have hyperkalemia when they are given RAS inhibition. Hyperkalemia in heart failure is not okay. We don't accept that because myocardium is already irritable. A patient whose LV function is 20%, we know that this patient develops acute ventricular fibrillation or VT anytime and is the commonest cause of death. Adding hyperkalemia to this kind of patient would increase the level of irritability and will cause arrhythmia, right? Therefore, we want to avoid potassium shifts as much as possible. Hyperkalemia increases with decreasing renal function. It is very common sense that as the renal function starts decreasing, the potassium levels may start increasing and can reach to alarming levels. Hyperkalemia is seen in a good number of patients who come to ICU. Almost 10% of patients who are admitted with ADHF have hyperkalemia. Almost 30% of patients who are admitted with ADHF and are given ACE and ARBs develop hyperkalemia, and 10% of patients develop alarming hyperkalemia with the use of current drugs. And therefore, I want to give good dose of diuretics, I want to give ACE inhibitors, ARBs. What next? I want to avoid increase in serum creatine, I want to avoid hyperkalemia. So does we have anything else? Therefore, was the need of the hour? Is the ARNI a good substitute for that? Probably answer is yes. ARNI is less likely to cause increase in the serum creatine doubling, right? Number one. Number two, it has less chances of development of more hyperkalemia and dangerous hyperkalemia, correct? It's a life-saving treatment for HFrEF, regardless of worsening of renal function. Any patient coming to us with any kind of serum creatine, I would think about ARNI giving to them, even in hospitalized patient for heart failure before discharge, correct? The reason being this slide, that it shows that clearly the drop in EGFR is less as compared to ACE or ARB with the ARNI. What do the guidelines say? SCC guideline 2024 says that ARNI should, in a patient de novo, should be on ARNI, a patient who has heart failure should be on ARNI as compared to as against ACE or ARB. ESC guidelines recommend the same. Our Indian guidelines also said that we should shift from ACE ARB to ARNI, and ARNI should be started in all patients who have ADHF before discharge, correct? And the reason quoted is same, that this patient is less likely to develop increase in serum creatinine and worsening of serum potassium. This patient, our patient has EGFR of around 32, so we don't need to bother much. A patient who has EGFR of 30 and above can be started safely on ARNI in a good possible dose. Those who have EGFR of less than 30 need to start on a lesser dose and increase the dose as required. But those patients who have EGFR of 30 and above, we can start safely on good amount of dose and increase the dose over 2 to 4 weeks. Patient who has already established CKD as our patient, what is the role of ARNI? That we know that ARNI, all the trials right from paradigm trial have proved that ARNI increases ejection fraction in this patient. A patient who has LV function of 20%, as against it becomes 26%, we know that it does make difference. Any jump of 2% or 5% will improve their longevity, will improve, add years to their life, and that years will be quality years and not just mere years. It decreases anti-pro-BNP. And we all know that anti-pro-BNP is just not a marker of heart failure, it is a marker of prognosis also. If you are not able to decrease anti-pro-BNP to less than 900, your patient is not going to do good. If you decrease it by less than 900, which is possible with ARNI as more against ACE/ARB. Sacubitril certain, there is ARNI also improves significant quality of life as seen by Kansas City QRS score, quality of life score. There is lower incidence of elevated serum creatinine. As I said, the doubling of serum creatinine is less with ARNI as against ACE or ARB, and the decline in GFR is also much less. Therefore, my friends, what it goes to say, that when there is a worsening of renal failure and the patient has acute decompensated heart failure, hospitalized, we want to avoid higher increase in jump in creatinine, we want to avoid jump in potassium. Therefore, you must think about starting ARNI before discharge of this patient. To summarize, renal dysfunction and heart failure commonly coexist in our patients. Very common scenario. Almost 40-50% patients have this problem. We have a lot of challenges in starting therapy, right? Which drug to give, what dose to start, when to start, how to increase. It's a very common problem, commonly asked to us many times. ARNI is preferred choice of RAS inhibition in such kind of patient because it shows improvement in its systolic function. There is less incidence of worsening of renal failure and definitely less risk of hyperkalemia. Thank you.
Thank you, Dr. Mahesh. You placed your case very well, and we have another speaker who will be countering or having his way of treating the patients. Adding vericiguat with SGLT2 inhibitors and beta blocker instead of ARNI would be the safest strategy as the starting choice, by Dr. Bhavesh Roy.
Good evening all. So, yeah. So going to the talk directly. So our female patient is a 65-year-old female, normal QRS duration, 90 milliseconds. Written to say that CRT is not an option and acute event is not there. ECG is not mentioning about any IVCD or anything. Normal angiography, ischemic heart failure, and she is in NYHA class 3 dyspnea with severe LV dysfunction with the ejection fraction of 20%. Blood pressure of 100 by 62 millimeter of Hg, and her creatinine is on admission I read as on admission 1.89 milligram with a GFR of 32. She was on diuretic digitalis, telmisartan and mineralocorticoid antagonist. Which she stopped for the last 2 weeks due to nausea and vomiting, and she was hospitalized for a heart failure 2 months back. So we are dealing with a patient who had an undiagnosed etiology of heart failure, undiagnosed etiology of LV dysfunction, and she is having anemic, and she was offered telmisartan and ARB and proper treatment, beta blocker, but still she is again presented with acute heart failure. So how to move ahead? So for me, approach to this patient will be first, we cannot bundle all the patients with the heart failure and acute decompensated heart failure in a one case, that it is all are with the heart failure with reduced EF. Each and every patient is different, and they are having different volume status, different etiology, different pathophysiology, and their phenotype is also different. And although we may try to fit all the patient in a one category, that they should be on this beta blocker or SGLT or ARNI or this drug, but they are all individualized. So I would like to further investigate this patient in the form of echocardiography with the GLS, find out the chamber sizes, whether it is a dilated or small LV, wall thickness and echogenicity. I will like to get her BNP, other specific markers, HRCT chest to see for the lymph nodes, get her cardiac MRI with the T1, T2 mapping and ECF volume, and get her urine taste for the protein SPI and UPI, abdomen USG, fundus, and if allowed, then PET also. So etiology workup, and assuming that because this talk is on the medicines, I assume that all the workup has been done and the workup is negative, and now patient is on the line of medical management only. We cannot offer any solution for the LV dysfunction. So now turns out that aim is only to improve the survival, to prevent the readmission and improve the quality of life. Patient is already on beta blocker, SGLE inhibitor and Penrinon, digitalis and diuretic, and she has altered RFT. And after treatment with the ARB-ARNI, I will go for the digitalis level at this point, find out whether lanoxin toxicity has occurred or not, because she was on and she has a creatinine altered, and remove the digitalis at this point. She is having anemia and this requires a treatment for the same. So the next slide is a class 1, class 2 and 2A, 2B. Again, to remind that what is the class 1, 2A, all people will be knowing. So level, this slide I want to be shown if possible. So this slide is from the European Society of Cardiology, and each and every person should be reading this guideline, whoever are managing the heart failure patients. They have beautifully divided the patient into the phenotypes. So it is not that heart failure with reduced EF or preserved EF only, or moderately or improved EF. It is based on the LV shape, LV morphology, and okay. Shall I wait? So we can divide the patient. So shown in this few slides, non-dilated LV cardiomyopathy, whether it is predominantly ARVC or it is predominantly hypertrophic cardiomyopathy or it is a predominant restrictive cardiomyopathy. So I will continue the, So based on the ECG finding, based on the echo finding, based on the cardiac MRI finding, we should be knowing about this. And this is the multidisciplinary approach. Each and every patient should have a discussion with the other specialty and pediatric as well as adult. Each and every patient should be having a cardiac MRI done, ECG, Holter monitoring, laboratory test done, and pedigree family chart should be done. These are the few slides which will tell that each and every patients are not same. Like even though patients are having hypertrophic cardiomyopathy, they can have a multiple type of diseases according to the different phenotype, like hypertrophic as well as dilated as well as non-dilated ARVC and RCM. Whether this lady is having some other problem also not, like sensory neural deafness is there or not. Like this patient is having visual impairment, whether patient has started having gait ataxia, whether patient is having myotonia or carpal tunnel syndrome. These are all the history examinations which should be taken, because I anticipated that this is a primarily talk for the physicians also, that physicians should be knowing that these are the things which should be noticed in your heart failure patients. And the entity can be diagnosed based on this, like one of our electrophysiologists has diagnosed this palmoplantar keratoderma and woolly hair, only just based on the examination. So I will skip these slides. like this last slide. This is the slide I will take, that each and every patient of acute heart failure should have this all investigation done based on the phenotype, whether they are having dilated, non-dilated, right ventricular or hypertrophic cardiomyopathy. And based on the ECG changes also, there can be a insight. This is the investigation chart. Each and every physician should be aware that all acute heart failure patients should have this investigation done. And now coming to our case, our drug trial. So this is the basic. Each patients should be on ARNI as compared to the AC inhibitor or ARBT. They should be on the beta blocker. They should be on the mineralocorticoid antagonist like aldactons or the eplerenone or the finerenone, and they should be on SGLT inhibitor. Now, benefit of simultaneous or rapid initiation of ARNI, beta blocker, aldactone and SGLT inhibitor is multifaceted. Everyone knows that it should be rapidly started. Rapid reduction in heart failure rehospitalization occurs. Rapid improvement in ejection fraction occurs, and improved use. But what is the problem? Problem is that only less than 25% of the patients are receiving all three guideline-directed medical therapy. Why? It is not that inertia of the physician or the cardiologist. It is probably the side effect, the blood pressure, wrong diagnosis, that we are giving a diuretic to a hypovolemic patients, restrictive physiology patients. When prescribed, the doses is also inadequate, and only 1% have received target doses of all three drugs. So where comes the role of the Versigut? So if patient is having GDMT started and still patient goes down and patient comes as a first heart failure admission, that patient is already on therapy, then comes the role of the Versigut. In that, we can change the trajectory of the chart, and we can make the second hospitalization less likely or delayed one. In our patient, we have given the AC inhibitor ARB, failed. If we give the ARNI at this point of time during hospitalization with a create of 1.89, there are very high chances that we may not further help her in improvement of the creatinine. We may take around 1 week or 2 weeks for the creatinine to come back further. Beta blocker is already given, SGLT inhibitor is already given, and that's where the role of another pathway comes. How the pathway is different. We have blocked already beta blocker pathway, we have stimulated the NPS pathway, we have blocked the RAS pathway, we have blocked the SGLT pathway, and now the role comes of another pathway where the totally different mechanism of action is there. And this mechanism of action is that another nitric oxide pathway. How the Versigut acts? It is a basically soluble, direct guanylate cyclase stimulator, and it promotes the cyclic GMP pathway. It helps the vascular remodeling. It helps the vessels to relax. It unloads the heart, and it decreases the fibrosis and inflammation in the long standing. What is the mechanism of action? Mechanism of action, we described that it provides the nitric oxide direct soluble guanylate. Exogenous nitric oxide pathway is activated. One tablet only. You can start with a 2.5 milligram once a day. Over 2 weeks, you can go to the 5 milligram and 10 milligram. Half-life is around, Tmax is around 3.5, and bioavailability is very good. Renal and hepatic dysfunctions are not affecting this drug, and it clears from the plasma within 1 day. So if patient is in NYHA class 2 or 4, 2, 3, 4, EF is less than 45, patient is having recent heart failure decompensation, IV diuretic use is off, then this Victoria trial eligibility was there. And what they have done, 2.5, 5 milligram and 10 milligram over 2 weeks optimization. The primary endpoint was time to the first occurrence of the composite, either death or the heart failure hospitalization. And the secondary endpoint was either the death or hospitalization or the second hospitalization or the all-cause mortality or the composite. The baseline characteristics were similar, and what they have seen that there was a significant reduction in the primary endpoint, and the primary endpoint was driven mainly because of the HFH, heart failure hospitalization. The total mortality or the overall mortality was not different. So I'm openly telling that Versigut doesn't affect the mortality, but definitely the first hospitalization was reduced after 12 months of treatment. So this is the p-value which is showing significant difference of 0.048 in the heart failure hospitalization, the second one. The rates of this adverse effects are significantly less. Postural hypotension, The syncope, pre-syncope or the dizziness were not significant with the varicegut, and all the guidelines are mentioning that if the patient is having acute heart failure, getting for the discharge on the guideline directed medical therapy, then very good. If first heart failure hospitalization, start the varicegut. If you are not able to start the guideline directed therapy, then the varicegut may be considered in the patient with the class 2 to 3, 4 who have had worsening of heart failure despite treatment with the ARB, beta blocker, SGLT and Pinrenon. So this is the therapy. This is the take-home message which I have taken from the other speaker, and I found it very good, summarizing all the treatment, possible treatment options in a heart failure treatment. Start her on starts declining by adding for our patient. Thank you.
Thank you, Dr. Bhavesh. We have another perspective of treating such patients, that is to give IV FCM, iron therapy. Dr. Hemang Bakshi talking about the intravenous ferrin carboxymaltose is the safest drug profile and should be started. Go to Dr. Bakshi.
Good evening. Thank you, chairpersons and moderators. Thank you, Dr. Kamal Sharma and Cardiocon team for inviting me for this event. So the patient that we are discussing is, I mean, a difficult patient. I mean, you all will agree with me that patients with heart failure, having cardiorenal syndrome, renal function is, compromised, and patient has got borderline blood pressure. You know that we have got 4 pillars in heart failure treatment, but these kind of patient, it is very difficult to give those medicines because as already discussed, there is all possibility that there is a further deterioration in the renal function, plus blood pressure is also borderline. So how to manage this patient? So do we have some other options? So we will discuss that, and that is iron deficiency in heart failure, which is most common and undertreated comorbidity. Right? Now, this 2021 update to the 2017 ACC expert consensus decision pathway for optimization of heart failure, they answers 10 pivotal issues about heart failure with reduced ejection fraction. And one of them is common cardiovascular and non-cardiovascular comorbidities with suggested actions. And these are the common non-cardiac comorbidities, and that includes obesity, CLD, diabetes, CKD, anemia, and iron deficiency. And as you can see, iron deficiency has got strong association with heart failure outcomes, and there are intermediate clinical trial evidences for modulating comorbidities, and suggested action is consideration of intravenous iron replacement for symptom improvement. Now, iron deficiency, which is a comorbidity that often goes unnoticed in heart failure. It is an important comorbidity. It is very prevalent in patients with heart failure, but often it is neglected. And as you can see, the prevalence is very high. Almost 50% of the patients with heart failure have concomitant iron deficiency, and this is the country-wise ID prevalence in heart failure, and it ranges from 37 to as high as 82%. And in India also, there is alarming burden of iron deficiency in heart failure, and 6 to 8 million people with heart failure has got iron deficiency. And it is estimated that 76% of the patient, that means 3 out of 4 patients of heart failure has got concomitant iron deficiency. Out of these, almost 50% has got absolute iron deficiency, and 27% has got a functional iron deficiency. Now, what is the definition of this absolute and functional iron deficiency? Iron deficiency is absolute when total body iron is decreased, and when the total body iron is normal or increased, it is called as functional, because this iron is inadequate to meet the needs of target tissue because of sequestration in the storage pool. That is because of the iron maldistribution, right? And here comes the role of this hepcidin, that is the hormone produced by the liver. It functions to regulate or inhibit the transport across the gut mucosa macrophages of iron. And in states of high hepcidin levels, like chronic inflammatory states, serum iron levels can drop because iron is trapped inside the macrophage, right? All right. So the causes of iron deficiency in heart failure can be reduced iron stores because of the GI blood loss, malabsorption or malnutrition, and it is measured by measuring the serum ferritin levels, or it may be because of the reduced iron mobilization by inflammation and pro-inflammatory activation, and that is that, as we discussed, hepcidin mediated malabsorption. And this reduced iron is measured by measuring the transferrin saturation. Now, the consequences of iron deficiency: exercise intolerance, decreased quality of life, increased long-term mortality, and in acute heart failure patients has chances of repeated rehospitalization. So what do guidelines say? The guidelines, ESC Heart Failure 2021 guidelines says that it is recommended that all patients with heart failure periodically screened for iron deficiency with full blood count, serum ferritin concentration, and TSAT, that is transferrin saturation, and it is a class 1C indication. And iron deficiency is measured by measuring serum ferritin. If it is less than 100, then patient is iron deficient. If serum ferritin is between 100 to 299, then you have to measure TSAT, and if it is less than 20%, patient is again iron deficient. Because in iron deficient patient, contractility of cardiac myocytes can be impaired, and it can be improved by iron supplements. As you can see, these are the control cardiomyocytes, and in iron deficient, you can see clearly the contractility is impaired, and it is reduced by as much as 43% in various studies. So subsequent addition of this transferrin bound iron could reverse this effect. Now the question is very clinically pertinent, whether you should give oral iron or IV iron. Oral iron is not effective because of so many reasons: poorly tolerated, GI absorption impaired, drug interactions, and hepcidin issues, because increased hepcidin levels typically in inflammatory states such as heart failure, precludes the resorption of iron from the gut. So oral therapy is out. You have to give intravenous treatment, and this is the recommendation of ESC that says that in patients who are iron deficient and LVEF less than 45%, as defined, we already discussed, it's a class 2A indication. And also, it should be considered in symptomatic heart failure patient who are recently hospitalized for heart failure with LVEF of less than 50% and iron deficiency. It is again class 2AB indication. So IV iron is the only valid treatment for heart failure, and ferric carboxymaltase is the drug of choice because of the evidences we have as well as lack of side effects. Now, it is given in 15-minute iron infusion, rapidly replenishes iron store. Extensive trials are available to, substantiate and better tolerability. And the evidence we have got is various FAIR HF, confirm HF and effect HF trial. And it is given in stable patients and in hospitalized patients also. Now once they are stabilized, they recommend that if they are iron deficient, you should give iron deficiency treatment. And FM AHF was the trial where ferric carboxymaltose for iron deficiency at discharge for acute heart failure was studied. So not going into detail, I would summarize that iron deficiency, even without anemia, is very common but neglected comorbidity in heart failure and is associated with worse clinical outcomes, low adherence to current guidelines in terms of screening for treatment of ID in heart failure patients is there. We need to educate the physicians. Intravenous FCM therapy is safe, leads to improvement in functional class, exercise capacity, and reduces hospitalization in patients with heart failure. And appropriate diagnostic and intervention strategies are needed to improve ID management overall in heart failure. Thank you very much.
I think so now our patient, index patient, I think this is also not working. Now it's stabilized. And then a strong HF data that you have to put on whatsoever way on GDMT, even some amount of GDMT, minuscule dose of each class with overlapping mechanism, with concomitant overlapping mechanism and additive mechanisms are better than one class going overboard. So I think we have to put on all GDMT. I think we all agree of that. So in India, we debate about putting a fifth pillar apart from all these four, the foundational four, the quintessential four. Would it be a kind of a cardiopulmonary rehabilitation or IVFCM or vericiguat? Which would be the fifth pillar here? And would you give IVFCM to this patient before discharge? Or would you make sure that this guy receive all four drugs as Dr.
Absolutely,
Mahesh
this
said
patient
that
is iron deficient, as it was there in the initial slide. He should be given, IV treatment.
First, we have to make sure that he receives the foundational four first, because he's before admission, ADHF episode, he's on ARB.
See, as far as possible, if we can give as many of the four pillars, if we can give to these patients, and the patient tolerates it, then it should be given first, and then, as you said, fifth pillar, you can use this IV iron treatment.
Yeah,
Is highly indicated.
actually the varicose thing comes up for worsening heart failure. This is his first ADHF, and he was kind of treatment. Now he was not on beta blockers are not mentioned. So first we have to make GDMT sure. And what about digitalis, continuation of digitalis in this patient? So what are your
So,
opinions on that?
Her creatinine was 1.89 and she presented with the
eGFR
nausea and
32.
vomiting.
Yeah.
And that nausea vomiting, I think it could be because of the digitalis toxicity and acute renal failure.
Yes.
So after ruling out the digitalis toxicity and renal failure is not because of any hypovolemia. If it is hypovolemia leading to the renal failure and beta block ARB is stopped and renal function starts improving, then go for the ARNI.
Yeah.
First.
Of course, this is
Build up
yeah.
the ARNI. Give the beta blocker, no diuretics, aldactone, and before discharge or after discharge, receive the IV iron. If I'm not able to build up the ARNI, creatine remains 1.89 or 1.9 or
Yes.
2, and patient is hypovolemic, euvolemic now, and still having creatinine of 1.92, then I will be afraid of further adding the renal injury with the ARNI and will go for the another pillar. Probably it will be isolazine or the varicegut or the lanoxin again in a tapered dose.
So varicose makes up for the shortcoming of the foundational period.
Yes.
Makes up it fits in the missing place where you cannot
Yes,
uptitrate
not as
that
a
way.
within
Dr.
the first
Mesh,
four.
if it had been the GFR case below 30 or stage 3 or 2B, late stage 2 or 3B, what would you have done? I say eGFR 28 ml.
See, we have seen n number of times that you give ARNI, you give ACE or ARB. Don't worry about much about creatinine rise or potassium rise. Monitor it. I'm not saying that don't neglect it. See it after 7 days, maybe around 2 weeks and 3 weeks. If it increases by less than 25% and potassium does not go beyond 5.5, it is safe to continue RAS
yeah.
inhibition. So my take would be beta blockers, RAS inhibition, maybe SGLT2 I would have
SGLT2.
loved to add over here because GFR is 32,
Yeah.
not bad at all. So I would have loved to add SGLT2 also before then adding MRAs.
So SGLT2 on board actually reduces the propensity for these guys renal effects,
Yes.
like so potassium
Yes, it
proclivity to
prevents
go up,
renal
yeah.
progression of renal injury, definitely.
Yeah, and then there have been ample data now for ADHF and in-house initiation of SGLT2
As you
inhibitors.
said, I would love to start maximum possible drugs in-house.
Yeah,
At least three before discharge.
yeah. So, and digital is off board, yeah. Any comments?
So, he rightly said that, I mean, these 4 pillars are fantastic drugs, and we should try to give as much drug of these 4 pillars to this patient as possible. And I mean, initially creatinine may worsen over a period of time, but ultimately it may stabilize. And in this particular patient, IV iron treatment over and above these drugs should be given.
And very narrow is coming on the verge of 30 ml GFR, then MR is a very quintessential component. So I think then aldactone, spironolactone, I think eplerenone, I think Hiramasar's stock is just flowing. So this is a very quintessential. Would you start in-house, or this would be the component you would leave for the future initiation when hemodynamics improve and some room for ruminaps develop for eplerenone's initiation later on?
If as you said, eGFR is dropping, then slightly I would be worried. I would be skeptical to start MRAs in this kind of patient. However, if it permits as a 32, 35, I would keep a watch, maybe 7 days, 10 days, 2 or 3 times potassium creatine, and then we can continue it. Or maybe what will be next on board.
Yeah, I think we're done. Any questions from audience? Yeah, it's for HEF-MREF, and this was HEF-REF, so at 20%. So of course, I think finerenone can also be used off-label, but fine arts for HEF-MREF above 40%, and this is 20% EF. So that's the catch here. But then this is safer in terms of potassium, finerenone, and in future it's going to strike. I think it would be as a front line, probably. Hiramasar will tell, yeah.
But and should we remove the ARNI completely?
No, I think if potassium are continually rising because of an RNEs are incriminated and MRAs are incriminated, then they have to be on way out, but you have to see why it's happening, because they are foundational pillar, they are disease modifying, not vericiguat. Or vericiguat is still
Versigouet
continue.
is, of
yeah.
course, that is the reason for him to
But
prove his
acute
symptoms.
reduction in mortality would come from beta blockers and MRAs.
All the four pillars were given. I was just concerned about how long have we to continue Versigouet and whether should stop ARNI completely.
Yeah, if recalcitrant, I think Dr. Kamal or Dr. Mesh, would you answer his question? Come here. He says that
Yeah, so most of the trials have looked into when to start. There is no trial to tell you stop. So either stop because patient has improved, or because if you've put suppose you start a patient on ARNI and EGFR at the time of starting was more than 30, you continue this patient, he remains stable and his EGFR is going to worsen because of cardiorenal syndrome. So the creatinine has started rising in a steady fashion without potassium rising. There is no guideline to tell you that you stop.
Thought
The
we continue
cutoffs
with
are
both
for
of them.
initiating the therapy. That was the quiz. So initiation you cannot do. Worsening is determined by potassium, as was pointed out by Dr. Fulwani, rather than worsening.
And clinical profile.
And the clinical profile. If the patient is actually feeling better, creatinine has jumped slightly up, doesn't mean you stop. No, you can go up to 25. Potassium is the determinant. And this was the quiz. So when you start, a vericiguat for 15, ARNI for 30. Paradigm HF only initially started with 45. Then it came down to 30. Metoprolol, remember, it's not that all beta blockers are okay at any GGFR, 15. Bisoprolol was one that was studied even below 15. Only data exists for below 15 for beta blocker is bisoprolol. Above 15, metoprolol and anything else. So DAPA, though they studied in DAPA CKD up to 25, but EMPA still has 20 cutoff. DAPA does not have a cutoff of 20. That was, so Ishtiaq got this one right. Ishtiaq, if you're there, you can come and get your prize. Ishtiaq. And I'll request moderators to hand over the prize to him. And we'll have a photograph if there are no discussions. Wonderful talk by all the speakers, chairpersons. Thank you very much.